A warm welcome to all. Today I am going to share with you the topic ulcer. Myself, Jenisha from Emmanuel Ulcer College of Pharmacy. Initially, ulcer are defined as a branch in the mucosa of the alimentary tract which extends through the mucosa into submucosa or deeper muscles. Peptic ulcer are chronic, most often solitary, that occur in any portion of GIT, gastrointestinal tract, exposed to the aggressive acid peptic juice. Acid secretion in the stomach. Look at the view on the acid secretion in stomach. Gastric acid secretion is the production of hydrochloric acid by parietal cell in the stomach, crucial for protein digestion, nutritional absorption and killing bacteria. It is stimulated by histamine, gastrin and acetylcholine and primarily inhibited by somatostatin. This process occurs in three phases: cephalic, gastric and intestinal. Then, phases of gastric acid secretion. How the gastric acid secreted in the body. Gastric acid secretion occur in three primary phases: cephalic, gastric and intestinal, regulated by neuronal and hormonal mechanism to optimize digestion. The cephalic phase starts via brain. The gastric phase is activated by stomach and the intestinal phase involves regulation as food. The cephalic phase consists of 30% of acidic, the gastric phase consists of 60% of acidic and the intestinal phase consists of 10% of acidic. Then the regulation of gastric acid secretion from parietal cells. Look at the view of regulation of gastric acid secretion from parietal cells. The parietal cells in the stomach gastric gland secreted hydrochloric acid by exchanging cytoplasmic H plus for extracellular K plus via H plus K plus ATPase, stimulated by acetylcholine, gastrin and histamine. This process is tightly regulated by neuronal, hormonal and paracrine to ensure digestion while protecting the mucosa. Regional and location. Stomach, duodenum, esophagus, then modified Jones classification of peptic ulcer. Type 1. Ulcer along the body of the stomach, most often along the lesser curves in crucial angularis. Type 2. Ulcer in the body in combination with duodenal ulcer associated with acid over secretion. Type 3. In the pyloric channel within 3 cm of pylorus associated with acid over secretion. Type 4. Proximal gastroesophageal ulcer. Type 5 can occur throughout the stomach associated with chronic NSAIDs and ASAUs. Signs and symptoms. Abnormal pain in the abdominal region, classically epigastric, with severity relating to meals time after around 3 hours of taking a meals. Duodenal ulcer are classically relieved by food, while gastric ulcer are exacerbated by it. Bloating and abdominal fullness. Water brush to pure back of watery acid from the stomach. Nausea and vomiting. Loss of appetite and weight loss. Vomiting of blood. This can occur due to bleeding directly from the gastric ulcer or from damage to the esophagus from severe or continuous vomiting. Melena, tarry, foul-smelling feces due to oxidized iron from hemoglobin. Rarely, an ulcer can lead to a gastric or duodenal perforation, which leads to acute peritonitis. This is extremely painful and requires immediate surgery. Pathogenesis of peptic ulcer. First one, aggressive force, H. pyloric infection, NSAIDs, aspirin, corticosteroids, cigarette smoking, alcohol. Imbalance between gastroduodenal mucosal defense force and the aggressive force. Mucosal defense force, surface mucus secretion, bicarbonate secretion into mucus, mucosal blood flow, apical epithelial cell transport system, epithelial degeneration capacity, elaboration of prostaglandin, increased gastric acid and peptic acidity, impaired defense, ischemic shock, stress related, delayed gastric emptying, duodenal gastric reflux, decreased retrograde motility impaired, neutralization by pancreatic alkaline secretion, associated diseases, chronic renal failure, hyperparathyroidism, chronic lung disease, chronic pancreatitis. Etiology and risk factor. Aggressive factor, H. pylori. Gram-negative bacteria can live in stomach and duodenum, break down mucus layer. Inflammatory response to presence of the bacteria also produces urease, form CO2 and ammonia, which are toxic to mucosa. Gastric acid needs to be prevented for ulcer to form, activates pepsin and injures mucosa, decreased blood flow, causes decrease in mucus production and bicarbonate synthesis. It promotes gastric acid secretion. NSAIDs inhibit the production of prostaglandin. These hormone-like substances help protect stomach lining from chemical and physical injury and inhibit acid secretion. Smoking, nicotine stimulate gastric acid production. Excess alcohol consumption. Alcohol can irritate and erode the mucosal lining of stomach and increases the acid of stomach that's produced. Stress may aggravate symptoms of peptic ulcer and in some cases delay healing. Defensive factors. Mucus. The stomach produces a lubricant-like mucus that coat the stomach and shield stomach tissues. Bicarbonate. The stomach can produce a chemical called bicarbonate that neutralizes digestive fluid and break them down into less harmful substance. Blood circulation in the lining of the stomach as well as renewal and repair help protect the stomach. Pathophysiology. Role of H. pylori infection in pathogenesis of peptic ulcer. H. pylori survive close to the stomach's epithelial cell layer. It produces adhesions which bind to membrane-associated lipid and carbohydrates and help in adhere to epithelial cells. H. pylori produces large amount of the enzyme urease. Urease break down urea to carbon dioxide and ammonia. The ammonia is converted to ammonium by taking a proton from water, which leaves only a hydroxyl ion. Hydroxyl ion then react with carbon dioxide producing bicarbonate, which neutralizes gastric acid. The survival of H. pylori in the acidic stomach is dependent on urease. The ammonium produced is toxic to the epithelial cells and along with the other product of H. pylori include proteases, vacuolating cytosine A and certain phospholipids damage those cells. NSAIDs, cyclooxygenase produces COX-1, COX-2, constitutively expressed, induced at inflammation site. Non-selective NSAIDs, selective COX-2 inhibition, stomach, kidney, platelet, intestinal endothelium, macrophages, leukocytes, fibroblast, endothelial cells, others. Diagnosis. Laboratory tests. Gastric acid secretory studies test for Helicobacter pylori, a blood test checking for antibodies to this organism, a breath test after drinking a substance called urea, and a stool test looking for bacteria. Other diagnostic tests, gastrointestinal series, you will drink a charcoal liquid called barium and then undergo a series of X-ray to check for an ulcer. Endoscopy, the doctor will carefully insert a thin tube with a tiny camera at the end down your throat through the esophagus to the stomach and duodenum. The endoscopy lets the doctor examine your digestive tract and take a sample of tissue to test your H. pylori if needed. Treatment. Reduction of gastric acid secretion, neutralization of gastric acid. H2 antacid. H2 antihistamines include cimetidine, ranitidine, famotidine, roxatidine. Proton pump inhibitors. Omeprazole, esomeprazole, lansoprazole, pantoprazole, ramiprazole, dexaprazole. Anticholinergic drugs. Pyrazipine, propandolone, oxyphenonium. Prostaglandin analog. Misoprostol. Neutralization of gastric acid. It's also called as antacid. Systemic, non-systemic. The systemic include sodium bicarbonate, sodium citrate. Non-systemic include magnesium hydroxide, magnesium trisilicate, aluminum hydroxide gel, calcium carbonate. Ulcer protectives. Sucralfate, colloidal bismuth subcitrate, anti-H. pyloric drugs, amoxicillin, clarithromycin, metronidazole, tinidazole, tetracycline. H2 blockers. Mechanism of action include cimetidine and all other H2 antagonists block histamine-induced gastric secretion. H2 receptor antagonists inhibit acid production by reversibly competing with histamine for binding to H2 receptor and the basolateral membrane of the parietal cells. Block histamine from stimulating the acid secretion parietal cells of the stomach. Reversible competitive inhibitors of H2 receptor. Highly selective for H2 receptor. Very effective in inhibiting the acid secretion as it depends largely on histamine. Comparison of H2 blockers. Comparing the drugs of cimetidine, ranitidine, famotidine, mixatidine. Comparing the bioavailability, relative potency, half-life, duration of action, dose, inhibition of CYP 450. The bioavailability of cimetidine is 80, and ranitidine 50, famotidine 40, nixatidine less than 90. Relative potency of cimetidine 1, ranitidine 5 to 10, famotidine 32, nixatidine 5 to 10. Half-life 1.5 to 2.3 for cimetidine, 1.6 to 2.4 for ranitidine, 2.5 to 4 for famotidine, 1.1 to 1.6 for nixatidine. Duration of action: cimetidine 6, ranitidine 8, famotidine 12, nixatidine 8. Doses for cimetidine 400, for ranitidine 150, famotidine 20, nixatidine 400. Inhibition of cytochrome 450, cimetidine 1, ranitidine 0.1, famotidine 0 and nixatidine 0. Pharmacokinetics: observed rapidly and completely except for famotidine. Food and antacids may be reduced absorption, distribute widely throughout the body, metabolized by the liver, excreted primarily in the urine. Cimetidine, ranitidine bioavailability 80, 50 respectively. Relative potency 1.5 to 10, half-life 1.5 to 2.3, duration of action 6 to 8 hours, inhibition 0.1 and dose 400 to 150. Therapeutic uses: used therapeutically to promote healing of duodenal and gastric ulcer, provide long-term treatment of pathological GI, reduce gastric acid production and prevent stress ulcer. Adverse effect: headache, dizziness, bowel upset. Cimetidine causes gynecomastic galactorrhea as it anti-androgenic and increases prolactin level. Interaction: inhibits cytochrome 450, leads to inhibits the metabolism of many drugs so that they accumulate to toxic level. Example: theophylline, warfarin, phenytoin, quinidine. Contraindication: renal impairment, hepatic failure. Proton pump inhibitors disturb chemical binding in stomach cells to reduce acid production, lesioning irritation and allowing peptic ulcer to heal. These drugs include omeprazole, rabeprazole, pantoprazole, lansoprazole, esomeprazole. Mechanism of action: block the last step in the secretion of gastric acid by combining with hydrogen, potassium and adenosine triphosphate in the parietal cell of the stomach. Most effective drug in anti-ulcer therapy: irreversible inhibition of H+, K+ ATPase to apical membrane of the parietal cells. Pro-drug recurring activation in acid environment: react covalently with SH group, weakly basic drug and so accumulate in the parietal cell. Activate in the parietal cell and bind covalently to extracellular domain. Acid secretion resumes only after synthesis of new molecules. Pharmacokinetic: bioavailability 50%, metabolism in liver, excretion in metabolic excreted through renally, onset of action half to 1 hour, duration of action 24 hours. Adverse effect: hepatic dysfunction, dizziness, nausea, headache. Interaction: inhibits oxidation of certain drugs, diazepam, phenytoin, warfarin. Antacid. These are basically substances with neutralized gastric acidity. Acid neutralizing capacity: number of mole equivalent of 0.1 NaHCl that produce to pH 3.5 by a unit dose of the antacid preparation. Systemic antacid: sodium bicarbonate, water soluble, acts IV, duration of action is short. Potential neutralizer: pH may rise above 7. Produces CO2 in stomach, leads to distension, discomfort. Increases sodium load level to worsen in congestive heart failure with edema. Large dose produces alkalosis. Characteristics of antacids: features: onset of action, duration of action, systemic alkalosis, effects on stools, sodium bicarbonate, calcium, magnesium hydroxide, aluminum hydroxide. Onset of action: rapid, intermediate, rapid, slow. Duration of action: short, moderate, moderate, moderate. Systemic alkalosis: yes, no, no, no. Effect on stools: no. Constipation, laxative, constipation. Non-systemic antacid. These are insoluble and poorly absorbed basic compound. React in the stomach with acid to form respective chloride salt. This again react with bicarbonate, is not spared for absorption, hence no acid-base disturbance. Aluminum hydroxide gel. The aluminum ion reacts, relax smooth muscles, leads to delay in gastric emptying. This causes constipation. Mucosal astringent reaction also leads to constipation. Ulcer protective sucralfate. Sucralfate is aluminum salt of sucrose octosalt. This substance adheres strongly to gastric and duodenal mucosa and adheres even more strongly to palatally denatured protein such as those found at the basal of ulcer. Since it is activated by acid, sucralfate should be taken on an empty stomach 1 hour before meals. The use of antacids within 30 minutes of a dose of sucralfate should be avoided. Anti-H. pyloric drugs: amoxicillin, clarithromycin, metronidazole. Combination must be required: amoxicillin, clarithromycin, tetracycline, metronidazole. And thank you.